This is Salma Schimmel at the AACR annual meeting for the Group Room, and this is the American Association for Cancer Research. We're in Chicago, and we're now joined by our good Group Room friend, Dr. Weitzel, Professor of Oncology and Population Sciences, Chief of the Division of Clinical Cancer Genetics in the Department of Population Sciences at the City of Hope Comprehensive Cancer Center in Duarte, California.
Good morning, Selma.
Hi,
Pleasure
Dr.
to be
Weitzel.
here.
How are you?
Good.
Dr. Weitzel, I understand if one family member is tested, say she tests positive or he tests positive, and you want to then test the cousins, that once you've established and I know I'm going to ask this wrong, so you'll clarify it for me, but once you establish the basic, I'll call it gene line.
The family mutation.
Right. That you can say to your cousin, and that first one could be more costly, but you have whatever necessary info that if you share that with your family member, they don't have to go through the entire.
That's right. You're exactly on the right track, Selma. That it's extraordinarily cost effective within families. You can make a huge impact because once you know the family mutation, whether it's, as we were talking earlier, an ancestral mutation that happens to be common in your population, or whether it's a private mutation in that family, once you know the key for that family, it's for good for everybody. And it goes from a $4,000 test to a $400 test.
Exactly.
It's a huge
or
differential.
Even less sometimes.
Or even
right.
less. And with today's next generation technologies, it should be much less. And then there's other things that happen. Uncertainty goes away. So, for example, when we do testing, 8 out of 10 times when we test women in our clinic who were looking for the gene mutations, we don't find it. I don't even use the word negative. I say the test was uninformative. And most doctors who aren't trained in this don't recognize that there are so many other risk factors and that there's risk left in that family if you haven't accounted for it. But once you've accounted for it, you can then test other family members and it's either there or it's not there. It's 50-50. It's like having a boy and a girl.
And I can't stress enough the importance and the moral obligation that if you are positive and you don't share that information with your other family members and cousins, you could be risking their lives.
And that's the important role of genetic counselors as well. That's their job, to help patients understand why they need to communicate this information. And they serve to facilitate it. You know, somebody doesn't talk to their sister. Well, can you talk to their daughter? Your uncle, your aunt, whoever. You do the workarounds in the families. We don't make up family strife. It's there.
Now, and recently there was some news that talked about the fact that even if you test negative, in this case I'm going to use the word,
Sure.
that doesn't mean that there is yet not another strain that you could test positive for.
Well, I think what you're
new.
getting at is the issue is if you test negative for a mutation that's known in the family, does that mean your risk is average? First thing is the risk doesn't go away. Every woman has a risk for breast cancer, unfortunately. But the issue is it higher than average still, despite that? And the reason we think that is in family studies where they looked at the most severely affected scenarios, that's how they found the genes, that's why we look there first. Well, does the gene account for all of that risk? Are there other things that are co-inherited that influence risk? There's no question that there are modifiers and things that are co-inherited. But the question is the magnitude of that background family risk important enough that you should treat these individuals differently? And I think at the end of the day, the true answer is probably that there is some slightly increased risk that goes with the family that doesn't track with the gene, but it's not of a magnitude that a woman has to second guess that she's just gotten good news if she's gotten a negative test result in a known family. So I think that there's proponents on either side. There's at least 2 papers very recently that both said no, their risk is no greater than the other family members who don't have, when you don't have a mutation, your risk is no greater. At least a couple papers in prospective studies that did this recently. But then there's others who still have different study designs and have seen some risk left over. So we're cautious about how we do that. The other thing we do is make sure we've accounted for everybody in the family. What if your father had a sister with breast cancer, but your cancer is tracking through your mother? Well, that risk is still there, even though it's not BRCA.
Right.
And so I'm very cautious about the way I counsel my patients to make sure that I've accounted fully for what's in front of me, the family history, and make sure I've answered the questions in hand.
Is it possible, now that we've identified BRCA1 and BRCA2, that we may ever identify yet another BRCA strain?
Well, there's no question that there's an emerging list that is getting longer and longer. A recent study by Mary Claire King's group showed that when they tested for 21 mutations, they found mutations in 12 different genes in ovarian cancer. Now, BRCA1 and 2 were the vast majority of these genes, but there were one-ofs and several other genes that are in the same pathway as BRCA1 and 2, which we now know cause disease similar nature.
Is there anything else you'd like to share on the testing front? You had mentioned something, and I don't know if we covered all of it.
Well, I think in the testing front, it's exciting because of the new technologies. We're expecting to be able to look at an ever broader range of these genes. Right now, we have to go sort of a la carte on the menu. Okay, it wasn't this, let's move to the next gene, with ever decreasing yield, but the cost doesn't really go down. So we're talking about maybe $10,000, $20,000 worth of testing that can probably be compressed into under 1,000 by the next generation sequencing. And so I think the way we do it is going to change. The doctors have to become better trained in learning how to do these things. I think the lessons we've learned is that it's not simple, that it does require some expertise.
For this generation of testing, will insurance cover the BRCA testing right now for patients that doctors consider at likely risk?
Well, the good news is there are guidelines that help us to know who, at least as a standard of care, thinks should be tested. The NCCN guidelines are a good place to start. I'm on that committee, as are most of the people I know who are very active in cancer genetics. And if they meet that guideline, Medicare pays for coverage, although you have to be affected to be covered in Medicare. Seems crazy, but even if there's a known mutation in the family, your sister can't get tested unless she's got cancer. That doesn't make sense. It's one of those fundamental lack of common sense sort of pieces.
Yeah, because you can't then do preventative surgery.
Right. That's right. And I would take a woman's ovaries out even later in life, even though I might dissuade her from thinking about preventive mastectomy. Ovarectomy, if I would treat her for ovarian cancer, it's worth
you can
avoiding.
Screen so much better.
You can, and with MRI and all the advances in screening, I can finally offer a woman an alternative to thinking about mastectomy. What I would say is an important area that we all have to do, and Deborah McDonald in my group is a PhD nurse who's on our faculty. She's studying social well-being of young reproductive age women who are faced with premature menopause. It's an important issue for your support community, is that a couple things about that. One, they don't have to avoid estrogen. We have great data now that if women get low-dose estrogen, enough to keep the vasomotor symptoms away, the hot flashes away, to keep them from fighting over the thermostat, I hear about irritability and other things, vaginal dryness, the sort of things that are all consequences, that can be avoided. And so we put a patch on them on the way out of the OR at the City of Hope, because we know that by giving them that low-dose hormone back, that they, one, don't feel bad, they feel great. Their bones stay stable. They feel well. They don't have to fear the oophorectomy. In fact, as one woman said to me, I've never seen my ovaries, Dr. Weitzel. So even the body image issues that go with the preventive surgeries are not the same. And we're just thrilled that there's this huge bonus. We reduce breast cancer risk by 50% in a BRCA carrier by removing their ovaries premenopausally. I mean, to me, that's a fascinating insight in biology.
And what about if a woman tests positive, or a man, at what age would you test the children?
First off, we don't test the children. Now, the offspring, if you want to look at adults, so I understand, but I was making a point, which is that we don't test children. Well, that's not entirely true for other cancer genes where familial polyposis can affect children as young as 12 years old. Then, clearly a medical necessity to test them. The question is, should we burden them with knowledge that they aren't going to use for years? And so, although there's work exploring whether adolescent women, young adult women under 21 should be informed, should they be given an option, I personally don't think we would encourage people to go there. Our bottom line is by 21 or by age 25 at the latest for a woman, because that's the time at which I would start changing their care. I would start doing MRIs in 25-year-old BRCA carrier with the hope that we're going to prevent, or rather diagnose, those early stage cancers. And we have good data now about MRI that it will do that.
So this is an important area of patient education for young adults.
Absolutely. And so I think understanding it, even though it's a minor part of the overall cancer burden, it's actually a major preventable component. And so it's the fact that we have tools, and that's the whole, we've been doing personalized medicine for more than a decade in clinical cancer genetics, identifying those who are carriers and then customizing their profile of care to anticipate that and to reduce risk and to treat the cancers more effectively.
Dr. Jeffrey Weitzel, Professor of Oncology and Population Sciences, Chief of the Division of Clinical Cancer Genetics in the Department of Population Sciences at the City of Hope Comprehensive Cancer Center in Duarte, California.
Thank you so much.
Pleasure.